I am going to talk to you a little bit today about AI and using AI in the operating room, the work that my lab does at MGH and Harvard, in conjunction with our colleagues at MIT. And so, because we're going to talk about AI, of course, the natural thing to talk about first is baseball. Has anybody read or seen the movie Moneyball by Michael Lewis? A good many of you have, but for those of you who haven't, the book and the subsequent movie with Brad Pitt and Jonah Hill is about Billy Beane and how he took the Oakland Athletics and thought about the limited amount of money that he had. And with the amount of money that he had, he couldn't be like the Red Sox and go buy home runs and strikeouts. So he had to think about data in a creative way, and he had to think about what are the other things that happen over the course of a game that contribute to wins or losses. And how can you set up a team to maximize these statistical advantages to generate enough wins on a small payroll to get to the playoffs? The issue in baseball, though, is that, this is covered up here, but the old way to keep data was you would keep track of the home runs and the strikeouts, so those were the easily countable events. And he had an advantage because he had a team of statisticians that was able to look at much more sophisticated data that was now entering MLB stadiums so that you could more specifically understand how fast is any given player and how should you set up your field position to maximize the ability of any player to get to a certain part of the field. So for those of you who watch baseball, you've probably seen that a lot of teams are now implementing the shift, and that's coming from a lot of position tracking data that we have on how certain players bat the ball into the field. And if we can do this type of analysis in sports, the question that arose as I was reading this book when I was in grad school was, how do we find these sub-threshold events that happen in the course of an operation that could contribute to a complication or death? Because there's a lot of things that we do over the course of an operation that we think, oh, this isn't that big of a deal. There's a little bit of bleeding here and there. What is the EBL? I don't know, let's negotiate. What do you want to call EBL? We'll call it 50. Great. And then we walk out the room. Where, what if there's a difference between 50 and 150, 150 and 250? We just don't know because we've been treating these as arbitrary values that we just sort of make up and say, well, there was no bleeding at the end of the case, so I think we're going to be okay. And so the way that we've been storing data in the operating room has not been conducive to allowing us to do something like moneyballing surgery and thinking about how we can find these extra wins to make our patient care better and higher quality. And that's because we've been doing things like storing information in very broad and general terms. Right? We store them as CPT codes or ICD codes. And so when we want to look back and see what went well in an operation or a group of operations in a population, all we know is, well, what was the indication? It was acute cholecystitis. What happened? Well, we did a lap chole. Did something bad happen? Yes, it was a bile duct injury. But I have no idea how that bile duct injury happened. I just know that it did. So how am I going to go in and intervene on that and think about it as a surgeon and say, well, what did I do wrong? In fact, there was a study that came out now almost 20 years ago that looked at a series of bile duct injuries, and what they found was 97% of these bile duct injuries are related to errors in human visual perception. But until they went back and looked at the operative video and compared it to interviews with surgeons, they had no idea. It was just assumed to be, well, this was unavoidable, there's a lot of scar tissue, it's not the surgeon's fault. But what it really turned out to be was a problem with confirmation bias. As a surgeon, when you're dissecting, I'm looking for key landmarks to figure out, okay, do I see a place where it's safe to clip and cut? And if I'm already looking for it and I have the pressure of my next case is coming up, I need to I'm already behind a little bit, speed through, yeah, that looks close enough, I'm going to go ahead and clip and cut that. And so people were dictating in their operative report, oh yeah, I found the critical view of safety, I clipped and cut this thing in the standard fashion, there were no complications. But that's the way that I perceive the operation to have happened, but I don't know what actually happened in the operating room. And in the Netherlands, where they actually video record all of their operations, they recently did a study where they analyzed 2 years worth of data, and what they found was that about 90% of the operative reports would state that they found the critical view of safety, and when they look at the video, fewer than 20% of them had actually done so, and that they had found about a 0.5% bile duct injury rate, which is significantly higher than you see in most published studies. And that's because most published studies have to deal with just sort of these big complication codes. And so we've been thinking about in our lab, how can we better access this data, and then how can we model it in an objective way, in a way where we can sort of get around the human problem of bias and perception. And so this is where we sort of not stumbled upon, but collaborated with a group at MIT that was working on self-driving cars. And when we approached them, we said, listen, we've been doing a lot of work in virtual reality simulation for surgery and really understanding how surgeons move about in simulated environments. What technology is available to do this with real operative data? And this was about 6 or 7 years ago, sort of before the more recent boom here in artificial intelligence. And so what we were able to sort of do is sit down with them and think about different concepts within artificial intelligence. And I show this, I know a lot of you are very tech savvy here. You guys have an amazing facility, an amazing set of teams, but I try to ground people in the taxonomy that I'm using just so that we're all using the same terms. So artificial intelligence is, of course, the big bucket field that refers to learning, but within that you have several different techniques. And so what we focused on in particular was thinking about how can we use automated learning techniques, how can we learn from the data that we're generating in the operating room to make decisions. And to be able to do that, we needed to use visual cues because an operation has a lot of vision involved. And so we are actually using, sorry, some of my animations here didn't work out, but what we heavily rely on is computer vision, which is a field that overlaps with some of these concepts in AI and is very much going to be using techniques like deep learning, techniques like reinforcement learning to really figure out how we can learn from certain cues, but also takes into account other processes, signal processing, pattern recognition, and image processing. And when that all comes together, what that really brings out is understanding what's happening in image and or video beyond just what's this pixel doing. So this is Tesla's Autopilot system. This is what's running in the background of a Tesla when you turn Autopilot on. And typically what this would show is as the car is driving, it highlights different things. And so the green that you see here is labeling pixels, but the way it's actually being interpreted by the machine is this is open space. The green labeled pixels are the areas where the car can maneuver itself into. The red boxes you see are pedestrians. You can't hit those, so you got to know where they are. The red cars directly in front are also obstacles. You also can't hit those. As it's driving down, there are some cars on the side that are in green. Those are not immediate threats to the vehicle, and so it models them differently. And so what we're really trying to get at here is not just a system that allows you to say, for example, is this a cat or a dog? Is this a car or is this a pedestrian? It's what is the context in which you're seeing these objects, and how is it going to influence the next decision that you make? Because artificial intelligence is not just about sort of what we read about in the press, which is, oh, this artificial intelligence system found a lung tumor, a lung nodule, and it could classify it as a tumor or not. Or this artificial intelligence system took a picture of a mole and could identify whether it was cancer or not. That's a binary decision about yes or no. What we were more interested in is how can we, in real time, influence decision making similar to the way that our cars are doing for us every day as we drive down the street. I have actually a very basic model Toyota from 2 years ago, and it can still give me the lane assist. It has the automated cruise control that can slow down and speed up. And so I have this extra decision support in my car for when I'm post-call and falling asleep and driving down the street. And if you can do this for cars, our question was, can you do this for surgery? And so our team set out with a pilot a few years ago where we were trying to decide, can we create machine learning descriptors that can classify what is happening contextually in the course of an operation? And can we do it automatically? So we were able to take, let me see, is the red here? Yeah. So we were able to take signal from the operative video. And so here what it's looking at is subtle cues like the convergence of lines, the instrument, where is the instrument pointing at? And does it look like anatomically, this is underneath the liver here, does it look like a visual pattern here that would suggest that the surgeon's attention is focused in this part of the image? And based on the surgeon's focus, can you then give some calculation about what they could potentially do next? And so this allows us to take information embedded in the video, like color, like texture, like relative anatomic position, to start to figure out the context of what's happening in an operation, not just to understand what's on the screen, but to understand what's going to come next. And so I do want to take you through one particular study actually that we just published, because I think it's important to understand the methodology of how these things are developed, because it raises sort of key points about what's important when you develop these algorithms and why there are specific limitations that need to be overcome. So we just published this, I think last week. It just came out in the Annals of Surgery, where we developed a machine learning system that could analyze sleeve gastrectomy. It's a bariatric operation where you basically take a sleeve of the stomach and create a smaller stomach for obese patients so that they can't eat as much. It's a restrictive procedure. And we developed a database of over 80 cases at the MGH. We have to anonymize them because obviously we want to protect patient privacy. The key important step is we had to have 2 surgeons watch every one of those cases. And they actually have to go through and annotate the videos. They have to mark what's happening when. Because an AI system is dependent on learning off of some sort of ground truth. It doesn't know any better. It's not a surgeon. It's never gone through surgical residency. It hasn't gone through medical school. So it has to learn from somebody who already has that knowledge. And so you can imagine sort of the amount of time and expense that it takes to have 2 surgeons not being in the operating room and instead watching cases to annotate. But this is the first step at least. So we had them annotate into 7 steps. And so we split up these steps. We tried to stay sort of as broadly applicable as possible. We were looking for specific things. When were the ports going in? Were they doing a liver biopsy to assess for fatty liver disease? How were they dissecting away the stomach? How were they placing their staples? And did they inspect the staple line at the end so that we could assess whether there's bleeding or potential risk of a leak? And then what we did was we created a computer model. So we used a couple of different techniques here. So first we trained a visual model. So the visual model is a set of neural networks that allows it to look at the specific frames distributed throughout an operation. And it's looking to see what within this image can I recognize. So sort of from that first example, where's the texture, the color, the relative anatomic position? It's looking for all these features to understand, well, if I look just at the image alone, what do I think is happening in this operation? So that's step 1. Step 2 is, well, we know that surgeries don't happen as a single time point. There are a series of events that occur over time. And there's valuable information in the time data because I can't start my operation until I put the ports in, right? If I don't make an incision, the surgery doesn't start. If I don't free up all the blood vessels from along the stomach, I can't start stapling the stomach away. And so there's logical information built into the time sequence of how an operation happens that can further improve the accuracy of this prediction. Because it can look at the visual image and say, okay, my guess when I see this image is that I am stapling the stomach. But then it can also say, well, wait, what did I see in the time points leading up to this? Did this surgeon free up the gastrocolic ligament? Yes. Well, the most natural next step after that is stapling. So that confirms as the machine, my suspicion that this is stapling of the stomach, and that's how I'll make that prediction. And so we combined these 2 models together. We gave it a cheeky name, SleeveNet, because it's looking at sleeve gastrectomy. And then we wanted to see how it performed against humans. And so we had to actually train this model. So we fed it, sort of the standard thing in machine learning is to split your data set into a training set and a test set. So we split up 70% of the video. And what happens is the machine gets to see the video plus the labels that the surgeons gave it. So it looks at it. It's like when you teach a child, you're like, this is a black couch. This is a red carpet. Same process. And then we take 30% of the video that the machine has never seen before, and we give it just the video alone. And then it works at trying to figure out, okay, well, based on what I'm seeing and what I've been trained to associate between the video and the label itself, I'm going to make an estimate about what step is actually occurring. And the big question is, how did it perform against a human annotator? And what we ended up finding is when we split it up, when you give it just the visual information alone, it's actually pretty good. 82% of the time just can look at the image and understand what step of the operation is happening. If you give it the temporal data, it gets a little bit better, not a whole lot, about 3% more. And you look at this and you say, well, it's 85.6% accurate. That's not 100%. Is that really good enough? When you look at the 2 surgeons and compare them against one another, they only agree about 86% of the time. So this machine can identify the steps of the operation just as accurately as any one of these surgeons. And so it's really about understanding what is the sort of benchmark to which we're going to hold these machine learning platforms to. None of us are perfect, right? When we see patients, we're not perfect. So why are we expecting perfection from our machines? One answer would be, well, I want my machine to be perfect because otherwise I would just go see a human surgeon. But the reality is that for us to be able to make progress, we have to understand that these machines can't do any better than the performance that we are teaching it on. And so for us to expect perfection from imperfect examples is a little unrealistic. And so if we want to move the field forward, we have to really understand what are the current levels of performance that we're reaching as humans. And if we're going to try to build machines to exceed that, why is it that that as human surgeons, we can only agree 86% of the time on what's happening in any given operation if we're both seeing the exact same video, right? Here's that issue again about human visual perception. We've all trained slightly differently. We all have slightly different experiences in our patient panels and how we go about seeing the world. And that influences how we interpret the visual information that we're receiving. So one thing that we can sort of potentially get to is, well, can we create some sort of neutral third party that has learned not just from 2, but from 50 or 100 surgeons that have seen this and better understand, well, what is the average surgeon going to see? Or is there some sort of ground truth that the humans can't understand? Let's see if this video works. I sort of want to show you how this runs in real time. And knowing that you guys have a great UX and UI team, I'm going to give the caveat that nobody on my team does UX and UI. So you're going to look at this and you'll be like, God, they need help. And yes, we do. So I'm open to any suggestions. Let's see if this plays. All right. So on the rightmost panel is the actual operation. And obviously it's sped up. I wish I could operate this fast. The middle is actually a probability map. And so what it's doing is, you can sort of see this red line. This red line is the active frame that it's analyzing. And it's trying to very quickly calculate a probability of what's going to go on next. And this operation, let me see if I can rewind that and play it again. This is a straightforward operation, this first example. And as you can see, sort of the probability of moving from one step to another is very sort of linear. It looks like you're walking down a set of stairs. The second case has a lot of intra-abdominal adhesions. There's all this omentum plastered up to the anterior abdominal wall because they've had prior abdominal operations. And what you can see here is that the probability of transitioning from step 1 to step 2 is actually a little bit lower. That's why you see sort of this confusion occur. And what this allows you to look at is a fingerprint of the case. And what you can tell is that if you have a complication, what you're going to want to do is go back and review the parts of the video where you see a lot of this confusion here, this red that overlaps across steps, because those are non-standard parts of the operation. The probability of you doing an operation that fits the prior 80, 100, 200 cases that the machine has analyzed is much lower than in this case, where this fits the pattern of the expected pattern perfectly. So if you are worried about a complication having happened, if I see this sticker on a chart, not that we're using it that way, but this is what we'd like to do, is that you put at the end of the case, this visual summary prints out, you put this sticker on a chart and this sticker on a chart. Everybody looks at this and says, well, this isn't right. This isn't a straightforward progression through the operation. You're more likely to give that patient slightly more attention in terms of looking out for non-standard postoperative complications, where there could be a thermal injury. We've actually caught a couple of thermal injuries this way that the surgeon hadn't thought about. When we were analyzing the data, we called them. We said, hey, your probability map looks a little off. You may want to just look. And we actually caught a leak early on day 3 before day 7 by being able to access this probability information. This is very computationally expensive to analyze all these frames. And so we've done some additional work to think about what are compression mechanisms that we can use to analyze these features much more quickly. Because when you try to scale this beyond just one operating room at a time, you're talking about analyzing just terabytes of data a second. And so it is inefficient to analyze every single frame of a 30 frame per second video, especially as it's happening in real time. So Daniela Roos, who's the head of AI at MIT, had a very interesting idea, which is, well, can you create some summarization of what's happening? So can you develop a computer vision system that looks at a frame of video, analyzes its features, summarizes those features mathematically, and then looks at the frames that are coming after it and decides how much additional useful information am I getting by analyzing this frame. If it is below a certain threshold, it throws it out and doesn't analyze it at all until it hits the next frame that gives it more information. And so what you end up getting is you actually only need about 10% of the video rather than the entire video to analyze. You're only analyzing about 10% and still getting about 92% accurate in identifying what's happening relative to analyzing all the frames at once. And so this saves you a lot of computational expense, and it also speeds up your analysis. So this allows us to scale, which is important because that's sort of what we're trying to move to next, which I'll get to. So what are the implications of this work? Just from an educational perspective, I think we talked about education, this allows us to rapidly index and bookmark operations. And so a surgeon doesn't have to sit there and scroll through an entire operation to figure out, oh, like how did somebody do this operation? Or if you have residents, you don't need your resident to watch your entire video. You could say, hey, today we're going to work on X part of the procedure. Here's my video library. If you just click through, it'll automatically find those steps of the procedure that you want to watch. So it helps for case preparation. Coaching is a big thing. University of Wisconsin, Caprice Greenberg, and Justin Dimmick at University of Michigan have a couple of R01 grants right now looking at surgical coaching. And so this can facilitate coaching as well, and as part of the coaching and case preparation concept feedback. This also allows for event-specific detection. I mentioned sort of about that thermal injury leading to leak. So we can look at these probability maps and determine when there may be an event that occurs that could lead to a complication or some sort of error in the operating room. Let me skip over some of this here because I'm going to get to it. So we're not the only group working on doing computer vision. The ERCAT group in France in Strasbourg has done something similar where they've been using machine learning to identify steps of the operation to predict case length. So they have real-time prediction of case length that they feed back to their scheduling people so that they know when a case is running long and when they need to redistribute the cases in their operating rooms at that hospital. And they're also able to detect instruments and identify specific instruments, and that helps them keep track of inventory. So they know how many staplers they're using in real time, and they know when they need to go down to the core to get more. The other study group that I work with is actually an international consortium called the Rhombozoid Group. And what we've been working on is trying to think of ways to make ground truth annotation easier. So it's a waste of a surgeon's time to sit there and watch a video for the express purpose of just annotating video for an artificial intelligence platform. However, most surgeons, particularly in academia, but also those outside of academia, are pretty invested in helping the next generation. And so we've sort of developed this educational platform called Think Like a Surgeon that presents operative video and then presents a case and says, you know, you have a patient doing with XYZ and an operation's about to start. Where would you make your first incision? And we distribute this platform to surgeons that are part of the Society of American Gastrointestinal Endoscopic Surgeons. And they're able to label, it doesn't quite work here, they're able to label where they would first make their first incision. And what it eventually generates is a heat map that shows where expert surgeons would do their first incision. But it also allows novice users, so junior residents, interns, medical students, to mark on this and receive feedback about, well, if I, as a junior resident, say, I'm going to start my dissection down here, it will then display sort of a probability map of where experts were most likely to start their dissection. So that provides immediate feedback to the resident, but on the back end, we're able to take the expert annotations and train a neural network to identify where those surgeons annotated, where they would want to start their operation, and then we're able to build in go, no-go zones into sort of a surgical GPS so that when you display the video of an operation, it can calculate probabilistically, well, you know, 80% of surgeons would probably make their decision within their first incision within this boundary. And you can actually set different thresholds. And so then you can have a system that can guide you through difficult cases. If you don't have enough experience with a specific case, or if you see something that's a little unusual, it's almost like crowdsourcing surgical guidance. And we've built that into an educational platform so that we can provide immediate value to surgeons that are doing teaching and for residents who are learning, but also train our systems to be able to understand what's happening in the context of an operation. And finally, the point that I talked about scale is important because we are really pushing this concept of a centralized repository of surgical data. It does us no good to have one silo of data at MGH, one silo of data in San Diego, one silo here in Minnesota, because we're not going to all see the same cases all the time. And so what we really need to do is actually combine forces and put together what we've been calling the collective surgical consciousness and say, well, what if we put all that data in the same place? And so that when you're training these machine learning systems to learn from different operations, you should be learning from the collective whole, right? You shouldn't be stuck in saying, well, I can only learn from the procedures that were done at my hospital. Well, what if I see a certain patient that somebody at the University of Minnesota has done 20, 30, 40, 50 cases of, and I'm seeing for the first time at MGH. It's silly that I have to be on my own and sort of depend on, well, maybe this, maybe that. I haven't seen this, but surgical principals would say. In today's sort of technology-driven environment where I can pick up the phone and FaceTime somebody and say, hey, how do I fix this leaky pipe in my house? Why can't I do that with my patients? Why can't I call somebody here in Minneapolis and say, hey, I've seen you publish papers on this, and I know you've done a lot of this. What I'm going to do is I'm going to tap into your system, and I'm going to understand. I'm going to use you as a GPS. But except I don't need you there. I don't need you to be awake. I don't need you not operating. I don't need you to ditch your clinic time. I don't need you to get on a plane. I'm actually going to put all of your knowledge into a machine, and that machine is going to be in the operating room with me, and it's going to guide me through the case and help me do the case your way so that I can try to do this as safely as possible for my patient that I have here in front of me. And the eventual goal is to not just have the operative video, but to have every single component built into this collective surgical consciousness so that we can understand not just what's happening in the operating room, but what were the decisions made leading up to that, and what are the decisions that are going to be made after the fact. And I think the idea here is to try to take that population level data to influence the individual patient's care. So it's really, this is personalized surgery. By incorporating elements of machine learning and elements of big data to really try to get at what is the best thing that we can do and how can we all learn from each other collaboratively. And ultimately, it's not, and again, my animation didn't work here, but it started out with a picture of the Terminator, which is automation, right? The robot that does everything. And I don't think that the near future of surgery is automation. It's really going to be about augmentation. You know, the Iron Man suit is really nothing without Tony Stark, but Tony Stark is also nothing without the Iron Man suit. And so it's this symbiosis between the technology and the human surgeon that's really going to be the future of clinical care, I think at least. This is not a solo effort. I have a big team at MGH, including people at MIT, and then my international collaborators with the Rhombozoid group that have been helping us sort of build out this collective surgical consciousness. You know, we have people in London, in Japan, in Canada, and then in a couple of sites in the US. And so we're slowly but surely making progress. And finally, sort of, I want to leave you with sort of one quote that Paul Rothman, who's the dean at Hopkins, gave at commencement a few years ago. And it's that we've all been working to try to get variation out of healthcare. And that's what technology has been helping us to do, right? But at the end of the day, I think it was talked about earlier in these panels, patients want to talk to a human being. And so we still need human beings in healthcare. The physician, the human physician needs to be there because there's some necessary variation that needs to stay. And that's that personalization of that patient-doctor relationship. And so that's why I think this concept of augmenting the physician is so important. Because at the end of the day, I think it's still important to remember that medicine is a healing art. And we need that personalized touch to really help patients move forward. And we can use technology to help us do that better, but it's going to be really hard to replace that one-to-one contact and that real relationship that you develop with somebody that gets that patient to come back, that gets that patient to actually follow instructions, right? So thank you very much.